So thank you for the nice introduction, and I do hope my talk is going to be revelatory, but I'll do what I can. I'm going to talk about artificial intelligence in ophthalmology, and I guess what I'm going to try to argue or try to convey is that, okay, there's a lot of hype around AI, but even leaving aside the hype, I think it does have the potential to transform healthcare. And furthermore, what I'm going to try to convince you is that ophthalmology will be the first of all the medical specialties to be fundamentally reinvented by this technology. And furthermore, what's exciting for me working at Moorfields is that Moorfields Eye Hospital, the NHS, and the UK can be at the center of many of these advances. This is my disclosure slide. I think it's important to highlight that I do act as a paid consultant for DeepMind. So if I start to get like overly enthusiastic and excited, as I'm kind of prone to doing from time to time, bear in mind that I do have that financial bias. So please take that into consideration. So I'm, as Edward has said, I'm a consultant ophthalmologist at Moorfields and academic at the Institute of Ophthalmology at University College London. And my professional career has been focused on examining the eye. And for the non-ophthalmologists in the audience and the non-optometrists in the audience, what you may not realize is that it turns out that ophthalmology, even as one medical specialty, has lots and lots of subspecialties within it. And I am a retinal specialist. So in effect, I only examine and deal with one part of the eye now. I'm super specialized in Moorfields. And so I spend my clinical time, my professional career now, is about trying to look through the pupil, trying to look through this keyhole into this dark cave, which is the back of the eye, and trying to visualize something that we call the ocular fundus. And the ocular fundus is essentially the back wall of that dark cave when you can look into the eye. So if you come to me and you've got like a problem with your cornea or an ulcer on the front of your eye or conjunctivitis, the chances are I'm sending you to a different clinic in Moorfields. I'm not going to deal with that myself. So the older I get, as I get older, I know more and more about less and less. So in any event, I want to look at the back of the eye. And I always like to give a little bit of historical perspective in my talks, just to kind of set the scene for where we are today and contextualize the advances. So this is the direct ophthalmoscope. And so the direct ophthalmoscope was invented by von Helmholtz in 1850, 1851, there or thereabouts. And so that was fascinating because that was the first time that it was possible to look through that keyhole into that dark cave and look at the back of the eye in a living human subject. Now, as a complete tangent to my talk, the person who should perhaps have got the fame for inventing the ophthalmoscope was not the German von Helmholtz, but was actually someone else who I think most, if not all of you, will be familiar with, the Englishman Charles Babbage from Cambridge. So it turns out, and you can read about this in the historical archives of the British Journal of Ophthalmology, it turns out that Babbage came up with a prototype ophthalmoscope 4 years before von Helmholtz. And so he came up with this prototype and he sought out the most eminent, the most senior, the most respected eye surgeon in London at the time. And he went to that eye surgeon, this eminent senior eye surgeon, and said, here's the ophthalmoscope. Look at what I've created. What do you think of this? And the most senior, most eminent eye surgeon took it, tried it, and said, why are you wasting my time with this? It doesn't work, and even if it did work, I wouldn't need it, and it wouldn't help me, and it wouldn't be of any use. And so dejected von Babbage went away, put it to one side, and von Helmholtz got the glory just a few years later. Now, as it turns out, that eminent senior eye surgeon was extremely short-sighted, literally myopic, and he wasn't able to use it. And so whether it was out of ego or out of, other kind of skepticism, he didn't really, embrace it or interact with it. Now, I love telling that story, and I think there's a deeper point there, was that if you're an engineer or if you're a computer scientist or you're someone who's got a new idea for technical innovation in healthcare, choose your clinical collaborators well, because we can provide a lot of additional value if you've got the right clinical collaborators. In any event, that was in the mid-19th century, and towards the end of the 19th century, you had the first attempts to not just to visualize the retina, but to capture the image in some way. And Jackman and Webster developed the first, or took the first photograph of the retinal fundus. And this is a picture of the setup that they created. Now, one of the challenges that they faced was in the sort of 1890s, how do you illuminate the dark cave, which is the back of the eye? So what do you think that they had to do? Well, essentially they used candles to illuminate the fundus, and I think it doesn't take a genius to see the kind of the flaws in that approach, but how long can you get a patient to hold a candle in front of their eye and as close to the eye as possible for the long exposures of these cameras? So it's perhaps no surprise then that the first ever picture of the ocular fundus was this one here. Now the circle on the top is the optic nerve, which connects your eye to your brain. And the larger white circle, that's just an artifact in the image. So it's no surprise then that ophthalmic photography didn't catch on in the 1890s. And in fact, it wasn't really until the 1950s and the 1960s that these retinal cameras became good enough, with the advent of like high quality 35 millimeter film and electronic flashes, that we could actually take these images. And that led to a golden era in ophthalmology, the 1960s, 70s, 80s, where we could actually now diagnose many of the commonest causes of blindness, whether it be macular degeneration, although that at the time that was referred to as senile macular degeneration. We call it age-related macular degeneration now, diabetic eye disease, glaucoma, and the like. And the cameras have gotten better and better. So at some point in the last 20 years, they moved from being captured on film to being captured digitally, to cameras that can take very high quality images even without dilating the pupil. And there's even something called PEEK now, called Portable Eye Examination Kit, invented by a guy that I trained with here in the UK, Andrew Bastauris, which is effectively a clip-on lens for your smartphone, which allows people with no medical experience whatsoever to essentially use their own phone, and if someone's eye is dilated, they can just bring the phone close to the pupil, and the autofocus on the camera will allow them to look at the optic nerve and the retina within seconds. And for anybody who's trained medically in the audience, they will appreciate how amazing that is, given the challenges of doctors and medical students doing ophthalmoscopy and learning the skill to look at the back of the eye. So, in any event, that's the type of image that you get with these state-of-the-art retinal cameras from the 1990s. So it gives us this picture of the ocular fundus. You can see here the optic nerve. The red lines are the blood vessels that supply oxygen to the retina. The whole thing is the retina, which is the nerve tissue that lines the back of the eye. It's like a layer of wet toilet paper that lines the back of the eye. And the center of the retina is called your macula, which is what gives you your fine central vision and your color vision. Now, until recently, that was the state of the art in eye examination, or at least until the 21st century, that was the state of the art. And so what happened then in 1991 was that we had this big breakthrough in ophthalmology and a paper published in Science by a guy called David Wong. Now, David Wong was a medical student, and he was doing a joint MD PhD in the lab of an electrical engineer called Jim Fujimoto in MIT. And they were working on using interferometry to measure the length of the eye. And he got the idea to adapt that to create a whole new imaging modality, which is called OCT, or optical coherence tomography. And so his PhD thesis is the description of OCT. And this is like, you know, sort of potential Nobel Prize winning territory for David Wong. Now, what is OCT? Well, this is an OCT scan of my eye taken probably 7 or 8 years ago. And I will bet you, if any of you have ever attended a hospital eye clinic with, you know, either as a patient or as a family member, you will have had an OCT scan done or seen OCT scans being done. OCT it's like ultrasound, but instead of measuring the echoes of sound waves, it measures the reflections of light waves. And of course, because the wavelength of light is so much less than the wavelength of sound, it gives very, very high resolution images. So for reference here, the retina is about 1/4 of a millimeter in height, in real terms. But the resolution of the scans is about 5 micrometers. So it's an order of magnitude better resolution than a CT scan or an MRI scan. And even better is that it's quick and it's safe and it's easy to do. So if you're a 5-year-old or if you're a 95-year-old, we can do an OCT scan on you, and we can do it over and over and over again, completely safe. Or if you were coming to Moorfields and, you know, I wanted to try and impress you or something, I would give you my little tour of the hospital and then take you and get you to have an OCT scan done and email it to you later. Because remember, this is the only part of your central nervous system, the only part of your brain that you can actually look at, you know, in this living state. Now, OCT has come to dominate ophthalmology. We now do more OCT imaging than all other ophthalmic imaging combined, and we regularly audit the number of OCT scans that we do at Moorfields. So, in fact, in 2017, we did around 1,000 OCT scans per day at Moorfields. And in fact, we often do 1,200 or 1,300 OCT scans per day. So that's kind of like doing 1,000 MRI scans per day. It's a huge amount of data. Now, that's good, but also it presents kind of logistical problems, like who are the people who can look at these scans and interpret the scans? You know, people like me. And how do we look at such huge numbers of the scans? So already you start to think, well, maybe this is a problem that artificial intelligence, and in particular, something I'll talk about called deep learning, may be very applicable for. That's one bit of context I'd like to give you. Another bigger problem I'd like to tell you about is this. Some people think that ophthalmology, mainly other doctors, like to think that ophthalmology is some sort of small medical specialty. They might think it's even a little bit of a cushy medical specialty, or they think it's some sort of niche medical specialty. In fact, ophthalmology is the #1 busiest medical specialty in the NHS in terms of clinic appointments. So in 2017, and this is data from NHS Digital, from the central NHS database, ophthalmology overtook orthopedics as the #1 medical specialty in terms of outpatient clinic appointments. In fact, nearly 10% of all clinic appointments on the NHS are related to ophthalmology. And that is a number that has increased by 1/3 in the last 5 years. So huge numbers of patients are being diagnosed and treated with these eye diseases. And so, for example, if you have a condition like glaucoma, you would often, once you're diagnosed, you would need to be monitored really for the rest of your life in many cases. And similarly for diabetic retinopathy and macular degeneration and the like. So the problem with that then is that we are drowning in the number of patients that we have to deal with. And the problem then, and there was an article, I think yesterday or the day before, I think yesterday in the Times, which highlighted the fact that some people are losing sight irreversibly because of delays in getting access to treatment. And that's a huge problem, not just in the UK, but in Europe and all around the world. So my idea then was that we would apply some of the latest advances in AI to these OCT scans that we do, so that we could effectively train a deep learning algorithm to be able to look at these scans and triage the scans, to prioritize the scans. Now, when I say deep learning, I guess many of you in the audience will be familiar with that, and particularly if you've heard Demis and others speak. But deep learning is the reason why AI has got so much hype around it in the last 3 or 4 years, particularly since a big breakthrough in 2012 in the field. But in 2015, Scientific American listed deep learning as one of the world-changing ideas of the year. Now, what is deep learning? Well, I'm not an engineer, I'm not a computer scientist, but the way I would describe it is deep learning is essentially a rebranding of this term called artificial neural networks. And of course, this is something that's been around probably since the 50s or 60s when it was called Perceptrons. And in the 1980s, it was something that got a lot of attention. But this is essentially a computational models that superficially, and I underline superficially, resemble the brain in terms of the way that they process information. And the key point is that they're not pre-designed or they're not pre-specified. So, the pre-kind of machine learning ways or deep learning ways that if you wanted to train or create a computer program to recognize a photograph of a cat would be that you would describe the features of a cat. You would do something called feature engineering. You say cat has whiskers, cat has a tail, some cats are ginger, some cats are not, some cats don't have whiskers, some cats don't have a tail, and describe all the features of a cat. And the problem was that despite many decades of work, that approach never really was accurate enough. With deep learning, you don't do that. With deep learning, you get 1,000, 100,000, 1 million, and preferably 1 billion photos of cats, and you present them to a neural network, and each time you present it to a network, you say, this is a cat, this is a cat, this is a cat, and it will create its own kind of abstract hierarchical representation of what it is to be a cat in a photo. And then it turns out that if you've got enough data, and if you've got enough computing resources, you can get very, very good results when you adopt that approach. And I choose the example of cats because famously, that was one of the examples that first was highlighted for these approaches to deep learning because of the huge numbers of photos and videos of cats on the internet. Now, this was very quickly applied to healthcare. Or at least the concept was applied to healthcare. Because let me preface everything else I'm going to say by telling you this is not yet being widely used in healthcare, despite all the hype around it. But nevertheless, it's the idea, it doesn't require a huge conceptual leap to say, if we can train a neural network to recognize a photo of a cat versus a dog, we could train that same network to look at a picture, we'll say, of a skin lesion and say benign or malignant. And in fact, work done by Sebastian Thrun, a big name in the tech world in Stanford, published in Nature in 2017, did effectively that. They got about 130,000 photos of skin lesions with labels of being benign or malignant, effectively, and trained a neural network to distinguish it. And then they evaluated the performance of the model by comparing it against 21 board-certified US-trained dermatologists on an independent test set predicting benign or malignant. And what do you think happened? Well, the algorithm was as good or better than those 21 board-certified dermatologists. Now, what do you think the implications of that are for dermatologists, for ophthalmologists, for healthcare, and most importantly, for patients? And I think that they're quite profound. However, as with everything, lots and lots of caveats with that. And the devil is in the details. And subsequent work has shown that there's lots of ways that the neural networks might cheat in this sort of task. And so it's been shown that if on the photographs that you train it with, if there's a surgical marking on it, or if there's a ruler in the photo, that might be more indicative of a malignant lesion. And it can learn those kind of shortcuts and then fail to generalize if you use it in the real world. So there's still, I think, lots and lots of caveats around that. And I'll tell you more in the context of ophthalmology. So this then very quickly has started to be used in ophthalmology. And of course, I'm biased, but I think that ophthalmology has been at the forefront of applying AI in healthcare. And so one of the first works was from the Google Brain team in California, published in the Journal of the American Medical Association in 2016, where they looked at training a deep learning model to look at retinal photographs. So not OCT scans, retinal photographs, and to basically distinguish between referable versus non-referable diabetic retinopathy. So, for example, in all patients who have diabetes, they should have a yearly retinal photograph done, and this will help to distinguish which patients need to be sent to an ophthalmologist, and in particular to a retina specialist. And they got very good results doing that. And in fact, they've done a lot of prospective evaluation and deployment of that, and this algorithm now, a number of years later, has become CE marked and is beginning to be used, although not yet, I think it's fair to say, widely. Now, as a slight tangent, I wanted to tell you about another result that Google Brain have done that has got everyone in the ophthalmology community and the retinal community very, very excited. And this was published last year in Nature Biomedical Engineering. And this was, what they essentially did was, they downloaded all the retinal photographs from the UK Biobank study. And this is, of course, a big study, 500,000 people in the UK. And what they wanted to do was use the retinal photographs and apply deep learning as a way to model the high-dimensional data that is the retinal photograph to systemic outcomes. So this idea of using the eye as a window to the rest of the body and try and predict cardiovascular risk factors from retinal photographs. And it turns out they could do it pretty well. So they could predict whether you smoked or not. They could predict whether you had high blood pressure or not. They could predict some other cardiovascular risk factors. However, it turns out that their approach didn't really offer much advantage from just sort of looking at classical risk factors for the patients, like what ethnicity they are or whether they smoke and different things like that in terms of predicting risk of heart attack and the like. However, two really interesting findings from this. The first is that they could map your retinal photograph to your age. So they could predict your age from a retinal photograph to within 3 years. Now, that is pretty astounding for an ophthalmologist. And even more strange, at least for a retina specialist, is that they could predict whether you're a man or a woman from your retinal photograph with very, very high degree of accuracy. Now, you may say, well, who cares? There are easier ways to tell if it's a man or a woman. And believe me, that has been said to me a bit like the London Bridge falling down kind of thing, has been said many times. But of course, that's not why we're excited about it. We're excited about it because I, as a retina specialist, have been looking obsessively at retinal photographs and OCT scans for at least 15 years. And I could not begin to tell whether it's a man or a woman from looking at the photographs. So there is this sense that maybe with this, effectively this kind of statistical modeling technique of deep learning, we can find new associations and discuss and get new insights into some of these conditions. Now, that's all the background then to this collaboration that I initiated in about 2015 between Moorfields Eye Hospital and DeepMind. And what an honor to speak here, 2 years after Demis has spoken. But essentially, what happened was that I had been reading about, or I'd been hearing about all the breakthroughs in deep learning and AI around 2013, 2014. And I was thinking, you know, how do I find somebody who's a deep learning expert who can come and help me and apply it to OCT scans at Moorfields? And so I was looking for different companies and, you know, looking for academic AI partners and going to UCL and other universities and trying to find people with that expertise. And then what happened, the eureka moment, was that I was reading Wired magazine in June or July of 2015, and I saw this profile of DeepMind. And in the profile, there was a section where one of the co-founders, Mustafa Suleyman, was being interviewed, and he sort of said something like, you know, we're interested in applying our technology to healthcare, to climate change, to energy, something like that. And that was the eureka moment for me, because I thought these are the people to contact. Because in the article, they highlighted the fact that DeepMind had been founded in London. 2 of the 3 co-founders from UCL were from UCL, 2 of the 3 co-founders from London, and Mustafa Suleyman, his mother was a nurse in Barnet on the NHS. So I thought, they are going to know what Moorfields is. So what I did was I tracked down, and this is again a complete tangent, but I tracked down Mustafa Suleyman's LinkedIn profile, and I took a 1-month premium subscription to LinkedIn so that I could send him a message without being connected with him. And I spent a few hours crafting like a short, not too long message to him, which effectively said, you know, I'm a consultant at Moorfields. We do X thousand OCT scans per day. There are people who are losing their sight because they cannot be seen and treated quickly enough. We should apply deep learning to these OCT scans. And by the way, we're 2 stops away from you on the tube. And so, to my kind of life-changing joy, he sent me a message that said, come and have coffee. And a few days later, I found myself in the offices of Google talking to Mustafa Suleyman. Now, I guess then, I don't need to give too much background about DeepMind, but founded in 2012, got a lot of attention in 2014 because acquired by Google, reputedly for £400 million, and arguably the world's leading artificial intelligence company. And I think that they are, you know, something quite special. Again, bearing in mind my disclosures at the start of the talk. Now, so my idea, and it doesn't take a genius, is to, can we apply deep learning to these 3-dimensional OCT scans? And so we started that collaboration, and we announced it formally in 2016, and then we started to work on it. And then it was really great then that in August 2018, we were able to publish the first results of that. And tremendously exciting for me because, you know, we got to publish it in Nature Medicine. And it was something that really we had spent, you know, a huge amount of time and effort. And just a really big collaboration. There's 34 different co-authors on this paper. And just bringing in amazing scientists from DeepMind like Olaf Ronneberger, and, you know, really senior clinicians from Moorfields like Serpeng Kaw, and, you know, senior scientists from UCL as well. And a real collaborative effort. I don't think it would have worked without the components of without the contributions of each of those parts. Now, it was also exciting because it was published and it was featured in the cover of Nature Medicine. And then, of course, this being artificial intelligence, AI, you cannot escape the hype around it. And so you had these sorts of headlines in the Evening Standard. Computer diagnosis could save sight of millions. Now, imagine how exciting that was for me. More importantly, imagine how exciting that was for my mother. And the amount of sharing of the details on Facebook and telling all the relatives in Galway and Ireland about how great her son is and what a genius he is and all of this stuff. Very exciting, but also just a little bit awkward because, of course, we haven't saved the sight of even a single person yet. What we've done is a retrospective proof of concept study, and we are not actually using this in real life yet. And in fact, what I've discovered is that getting to the point of, I used to think that publishing the research paper was the hard part. Now I realize the reality is actually going from that to implementation. And that's both challenging, but also very, very exciting to learn about that. And what I would love to be involved with is a project that begins with an email and ends with actually something that's used in millions of people. And that's what really excites me now. So what did we do? Well, we created a neural network architecture that consisted of 2 neural networks. And what we did is that you can start on the left. There's the raw OCT scan. So that's essentially about 65 million numbers in a 3-dimensional grid. And that is fed into a segmentation network. And that's a neural network that's been trained with about 877 manually segmented images. So in other words, what we did was we got 900 OCT scans, there or thereabouts, and we spent 6 months or more, a team of 10 or more people, painstakingly delineating every little cyst on the OCT scan, or every bit of scarring or bleeding, and all of the features of an OCT scan. So that the first neural network can actually look at the scan and create this representation, this intermediate representation of what's going on in the scan, delineate all the pathology. That is then fed into a classification network that we've trained with about 15,000 disease labels. So we've said, here is a macular hole, here is diabetic macular edema, here is this, here is this, here is this, so that it can learn to kind of make a triage decision and a diagnosis. So the referral suggestion here is, so it says urgent referral, semi-urgent referral, and then it looks about 10 different features on the OCT scan, 10 different diagnoses that an ophthalmologist or a retina specialist would look at. And so it's probably not exciting for you, but for an ophthalmology audience, it's really cool to hear that it could diagnose choroidal neovascularization, cystoid macular edema, full-thickness macular hole, partial thickness macular hole, central serous retinopathy, vitreomacular traction, epiretinal membrane drusen, and probably a couple of others also. Now, we deliberately did this 2 neural network architecture for some good reasons that I'll tell you, but as a byproduct, one of the nice things is that it gives us a lot of quantitative information about the bleeding within the retina, about the leakage of fluid, the scarring, and other features within the retina that is not currently available in any OCT device. Another thing to highlight is that we trained it on more than 50 different retinal diseases. And so that was the advantage of having the Moorfields data set, which was so large and heterogeneous, covering mild, moderate, and severe disease, covering a range of different ethnicities. And in fact, the only retinal diseases we didn't train it on were if you had a rare disease such that there was only a tiny number of people with that disease, we didn't share that data because we didn't feel confident we could anonymize that data robustly enough. So if you're the only person with disease X, then we didn't share that data. Now, here's a prototype of the viewer. So on the left, you can see the raw OCT scan, the intermediate tissue representation, and then the heat map for one of the disease features. So you feed in the OCT here. 15 different disease features are delineated. And for each of the disease features, we create a heat map. So this is a fibrovascular pigment epithelium detachment. And above it, you can see subretinal fluid pooling under it. And then at the top there, it says CNV, diagnosis probability 99.5%. And it recommends urgent referral to see somebody like me. Now, here's a patient. This is the kind of algorithm in action. This is a man in his 40s with poorly controlled diabetes. And what you can see is that the algorithm is delineating what we call diabetic macular edema, which is waterlogging of the retina. And it's delineating those features. It's saying macular edema, 98.5% certainty, and it's recommending semi-urgent referral. The other thing that you'll see is that there's this kind of flickering of the images, and the green column on its side is moving back and forth. That's because we do something called ensemble machine learning. So we actually, what I haven't told you is that we train multiple neural networks for each task. And so it's effectively like asking 5 different expert clinicians for their opinion. And so in most cases, they're all going to agree, and they're all going to say this is disease X. But in ambiguous cases, you can see that actually they may disagree. And that may be useful information in terms of, managing a patient. So we then got 1,000 new patients, again, historical data from 1,000 patients who had presented to Moorfields and had an OCT scan done at their first visit. We ran the algorithm on those 1,000 cases. It had never seen those cases before. And we wanted to look at how many errors that it got against our gold standard diagnosis, particularly with regard to referral decisions. And so what this shows is that it had about a 5.5% error rate on the referral decision. Now, we then got 8 human experts at Moorfields. Experts 1 to 4 are 4 consultant ophthalmologists at Moorfields who are retina specialists, who are world-famous retina specialists at Moorfields, some of whom have more than 20 years of experience. Experts 5 to 8 are optometrists at Moorfields who have some experience looking at OCT scans. And we got them to look at all 1,000 cases and give their referral decision. Now, how do you think that they did? Well, here's how they did. So the algorithm did better than all 8 human experts except for experts 1 and 2, where it did better, but it wasn't statistically significantly better. Now, before we clap ourselves on the back too much, let me tell you that whenever you see AI hype around AI beats the best doctors, you should be cautious, because a lot of the time when you dig into the details, you'll find that the doctors or the other healthcare professionals are not doing a task that they do in real life, or they're doing that task with one arm tied behind their back. So in this example, the ophthalmologist and the optometrist would never, ever look at an OCT scan in isolation. They would have a retinal photograph, they would know the visual acuity, they would know the age of the patient, they might have a line of history. So to make it a fairer comparison, we put a lot of thought into how to do that. And so we repeated the exercise and gave the human experts all that they would normally have if they were assessing a patient in a rapid access clinic. And not surprisingly, that did make all the human experts a lot better. And the best human expert got down to 5.5% error rate, which was the same as the algorithm looking at the OCT alone. And before you ask, adding the additional data to the algorithm didn't really improve the algorithm's performance. Now, you may say, well, what did it get wrong? And I won't go into the confusion matrices, but what the BBC picked up on was AI did not miss a single urgent case. There's me there, and pretending to examine Elaine Manna, who's a patient of mine at Moorfields who has macular degeneration. As an aside, Elaine is probably one of the main reasons why I initiated this collaboration. And she's talked very eloquently and publicly about her macular degeneration, but she lost her sight in her left eye more than 10 years ago when there was no real good treatment for this condition. And in 2012, 2013, she started to lose her sight in her good eye. She went to her optometrist. Optometrist said, I think you're developing wet AMD in your good eye. You need to go and see a retina specialist urgently, because we now have treatment. We have these injections we give that are good treatment. She gets an urgent referral, and she got an appointment in another London hospital 6 weeks later. Now, if that was my mother, I would want her to be seen in 6 days and not in 6 weeks. And imagine a situation where you're blind in one eye, starting to lose the sight in your good eye, and you're told there's a treatment, but you have to wait. And that some of that loss may be irreversible. Now, fortunately, Elaine was able to get into Moorfields by some other route and got seen and treated, and she's doing very well with the treatment. But in effect, her case encapsulates why I initiated this collaboration, because it was about getting people like her in front of people like me as soon as possible by whatever means possible. Now, what did it get wrong? Well, interestingly, when we looked at the best human experts and what they got wrong, it turns out that a lot of the time, the things that they got wrong were at least ambiguous cases. And when we looked at our gold standard, our reference diagnosis, we actually thought, maybe our best human experts are correct. And they haven't made a mistake here, actually. But interestingly, that was also the same for the algorithm. So we trained it on TopCon OCT, but we also got it to work on Heidelberg because of the way that we set up the neural networks with the 2 neural networks. So one of the things about this is that when we trained it originally on TopCon, when you take a Heidelberg scan from a different vendor and run it through the algorithm, the networks will not be able to make sense of it. And it effectively looks like kind of gobbledygook when it's looking at the retina, and then it has a 50% error rate on the diagnosis. And so this is one of the limitations of deep learning. But the way we set it up with the 2 neural networks was that we could retrain the segmentation network with a small number of scans from the Heidelberg device. And now it knows what it's looking at when it gets a Heidelberg scan. And we can keep the same classification network, and then we have an error rate of about 3%. So the hope is that you don't have to, if you get a new device or upgrade your device, you don't have to wait for another 10,000 or million scans to be obtained before you can retrain your system to tweak for this. Now, I think that this has got a lot of possibilities. One of the things I'm interested in is in the context of medical education. And I read this book from Gary Kasparov, which is really good, Deep Thinking, Where AI Ends and Human Creativity Begins. And the last chapter was really fascinating because he said, well, look, after he lost to Deep Blue, people didn't stop playing chess. In fact, young people learning chess began to use chess computers as part of their ways to train. And it turned out that had 2 very interesting effects. One is that people now become grandmasters at an earlier age than before, when Bobby Fischer and Gary Kasparov were kind of outliers very much in the age. And the other thing is that there's a much broader geographic distribution of high-quality chess players now than before. And I think that some of these AI systems, particularly the interpretable systems, may greatly facilitate this, because if I'm an expert at looking at OCT scans after 10 years of obsessively looking at them, I'll bet you that someone could become a bright medical student, could become as good or better than me in 10 months, or maybe even in 10 weeks, given the right tools to help them develop that skill. Now, just a couple of things to say, which I've already touched on. One is that the AI Chasm is the gap between a cool demo and actually having something that's you can use in millions of people. And we're still very much working on that. And in March of 2019, we did a live demo of the algorithm, the updated algorithm. So we've been working on the technical maturity of the algorithm. So it will run in a fraction of the time with a fraction of the computing power using a cloud-based application programming interface. And so we're really excited that we've been able to move forward on that side. And we're also moving forward on the clinical validation. And this is a work that I just highlight from my collaborator and I, Alistair Denniston, published in The Lancet Digital Health, a systematic review and meta-analysis where we highlighted that we looked at more than 20,000 studies on deep learning in medical imaging, and only 14 of those 20,000 were actually high-quality studies in terms of the clinical methodologies that they use. So there's still a lot of work that's required to be done on the clinical validation of these algorithms. They have huge potential, but there's lots of ways they may not work. And we're working on this sort of global validation of the algorithm now. And then, of course, there's no good in having just an AI system if you don't have pathways upon which it can be implemented and adopted. And so increasingly, we're looking at use of OCT in the community and in the home, and AI complementing that very nicely. Now, in my last 5 minutes, I wanted to just change the subject a little bit. And just to say, if all of the stuff that I've been talking about already, if I wasn't enthusiastic or excited enough about all of that stuff, I want to turn it up a level now for my last 5 minutes and tell you about the thing that I think is the biggest thing that I'm involved with. And let me tell you, I'm probably one of the few people who thinks that at the moment, okay? And particularly if there's any machine learning experts in the audience, you may feel free to throw stuff at me during the next 5 minutes as well. And I should be cautious if I'm saying this on YouTube as well, but nevertheless. Now, this relates to this announcement that came out just a few weeks ago, and it's about how Moorfields is using something called AutoML to enable clinicians to develop machine learning solutions. Now, what is AutoML? Well, at the moment, one of the problems with applying AI, and in particular deep learning, is that you need a lot of computing power, and to a large extent, you need specialized technical expertise. Now, that's improving a lot in the last few years, but you still need to be able to code, you still need to do things really well, you do need to have specialized technical expertise. And you need to have large data sets and lots of other stuff. But essentially, there's these barriers to the implementation, to the development of AI. And so I was really excited then when I read this article in the New York Times at the end of 2017 by the tech reporter there, Cade Metz, about AI that can build AI. And so he talks about this thing called AutoML from Google and other platforms from other companies like Amazon and Microsoft and others, and Baidu and a number of others, which essentially automate the process of developing deep learning models. Very, very exciting for me. Building AI that can build AI. And so just about 3 or 4 weeks ago, we were excited to publish our first work using one of these automated deep learning platforms in the journal Lancet Digital Health. And what we showed in that article is that 2 members of my research group, who are ophthalmologists with no coding experience, were able to use this automated deep learning platform to develop medical imaging classification tools, deep learning tools, that got results comparable to state-of-the-art. And let me emphasize again, with no coding experience whatsoever. Now, what we did was, we got 5 publicly available medical imaging datasets. So because this was involving the cloud, we didn't want to use Moorfields data until we had gone through an approval process and done our data protection impact assessments and all of the necessary rigor around using it. So we were so excited, we just got a load of publicly available data sets, 5 of them. We got skin lesions, we got adult chest x-rays and pediatric chest x-rays, all publicly available. We got OCT scans, and we got diabetic retinopathy retinal photographs. And we uploaded these to AutoML, and within 24 hours, we were getting very good results, and in many cases comparable to state-of-the-art. Now, loads of caveats and cautions around that as well still, but the excitement for members of my research group as clinicians and clinical academics who've been kind of like, and I should speak for myself here, kind of like in awe of the people at DeepMind over the last few years and the kind of skills that they have, and kind of wishing like if we could turn back time, we could do like a PhD in machine learning alongside our medical studies. the excitement that we felt then starting to get a hint of being able to do something like that ourselves. Now, as an aside, when we were submitting that to the Lancet, one of the things that the editor, when it was near acceptance, said, "One point we hope you will be able to address in the revision is to emphasize that automatic ML tools will not necessarily replace AI experts." I couldn't help smiling, because I have spent the last 4 years being asked, will AI replace doctors? And I've had to try to kind of like field that question over and over and over again. So it's nice to turn the tables a little bit in that. But let me tell you, it won't replace AI experts, okay? There's some things that this will work well in, and other things where, we have to be more cautious. And so my last couple of slides then to say, well, why am I so excited? Well, I think, and I'm borrowing a phrase from somebody else here, I think this could be a bicycle for the mind. And so this reminds me of this diagram that was in Scientific American in 1973, where it looks at basically plots sort of energy consumption per gram of body weight per distance traveled of different animals and machines, and combinations thereof. And up at the top left, there's a fruit fly. Somewhere over there, there's a helicopter and a jet fighter. It turns out that the most efficient is a man or a woman on a bicycle in terms of energy used per weight per distance traveled. Now, that was picked up by no less a person than Steve Jobs. And I saw this on Twitter a couple of months ago. This was an advertisement in August 1980 about the personal computer, where he says, when we invented the personal computer, we created a new kind of bicycle. Now, when we think about that time, I think it's very difficult for us to remember back to the 70s and early 80s when the personal computer was not a ubiquitous item. And so, in fact, here it says, today, most people aren't even aware that the personal computer exists. The challenge of our industry is not only to help people learn about the personal computer, but to make the personal computer so easy to use that by the end of this decade, it will be, in every home, essentially. Now, what's interesting was, alongside that article, there was all these interviews and newspaper pieces around the reaction at the time when Apple were creating the first personal computer. And the people in the computing industry were like, why would anybody want a personal computer in their home? We make mainframe computers for corporations to do the payrolls of their staff. Why would anybody want that in their own home? And moreover, the personal computers that Apple are making are kind of not good. They're simplistic compared to what we can do. Why would anybody want that? In fact, it turned out that once you gave people that, they could determine so many different applications that no one would have predicted, before that this was widely used. And so one of the things that I believe is that deep learning is effectively just a statistical modeling technique for modeling high-dimensional data. But I bet you that if you can empower healthcare professionals or other scientists or other engineers and the like, that we will come up with hundreds of different applications for this. And that's what really excites me. Now, the truth is that, much as I love the people in DeepMind, and maybe I shouldn't say this on camera, but they would, if you left them to their own devices doing ophthalmology, they would just continue to work on diabetic retinopathy screening or OCT and optimizing those things. And actually, it needs clinicians to be able to identify new use cases and for this kind of proliferation of this technology. And I do believe that, as Andrew Ng says, that AI can be the new electricity and can have these transformative effects, even if there isn't any more fundamental breakthroughs in the science. Now, I like to present this when I give a talk to ophthalmologists or or to clinicians. I say, if not you, then who? Because I say, look, you can go and download these publicly available data sets tonight, if you'd like. You can sign up for a free account on one of these automated deep learning platforms, and you can start to play around with this. Now, you do have to be careful. Don't use your own hospital's data unless you go through an approval process and ethical approval and governance approval and all of that stuff. And then the other caveat I'd say is, just to be clear, nobody is suggesting this should be used in patients anytime soon, okay? Even with a bespoke deep learning system from the world's leading deep learning experts, there are cautions about using those in real patients. And that's doubly the case if we're talking about ones made by people like me. But nevertheless, I can already think of so many different applications of this technology that don't necessarily involve direct clinical care, but effectively I can think of an ophthalmic research toolkit that could be facilitated by this work. And we're really just starting to get into that process now. So the people in my research group, Siegfried and Livia, they're the two people who did all the hard work. They're the people without the coding experience who actually tested this. And so I think that we can begin to really reinvent the eye examination, take technology like the slit lamp, which hasn't changed for 100 years, reinvent it for the 21st century. And my last slide, because I've talked far too long, is to say, of course, I get carried away in my excitement for these things. We must do robust clinical validation. We must balance enthusiasm with caution, particularly in healthcare. There's lots of ways where this technology might not work. We need to be very careful about it. I think we will start to get many new insights using this technology. And Demis Hassabis talks about AI-assisted science in a very inspiring way. But I think we're entering a phase now of democratization and industrialization of this technology. And these platforms, like these automated deep learning platforms, that make it possible for people like me, without deep technical expertise, to be able to train these algorithms, is really going to be the next major step forward in this technology. And then lastly, that's my email address and my Twitter handle. Thank you very much.
Thank you, Pearce, very much. I promised you something later, and I think that lives up to billing. That was one of the most significant talks I've heard in a long time, so thank you very much. Questions, please.
Thank you for a fascinating talk. It was really inspiring. I had my first ever OCT scan a week ago today, which was fine, just fine, luckily. I was amazed at how quick it was. It was quicker than a blood pressure test. I was sat there craning my neck thinking this is going to be uncomfortable. She said, it's done. Yeah. With that speed in mind and the speed of the interpretation in mind, can you see a future for this as a routine examination in a GP surgery, for example, not going down the ophthalmological route, but just, oh, hello, patient, sit in front of this machine and we'll see if we can detect any problems with you, like a blood pressure test or a blood test.
So in 2017, Specsavers announced that they were rolling out OCT across all their branches in the UK and around the world. They have 740 branches in the UK and do 9 million eye examinations per year. And a number of the other major chains have started to follow suit. So it's increasingly available in the high street. We have an Israeli company called Notal Vision, and they've developed a home OCT device. And Novartis have also announced publicly a collaboration with Compact Imaging from California to develop a home OCT device. So I think in the next few years, we're going to see a lot more care of chronic eye diseases locally for patients. And I think where AI is going to come in is bringing world-class expertise, bringing like Moorfields expertise or similar into the community and into the home, because that has to be much better for patients.
Thank you.
Yeah, again, thank you very much. It was an amazing talk. Oh, sorry, over here. I found it interesting it wasn't mentioned. It seems to be a lot of the focus is bringing the technology up to date with doing what experts can do at the minute, which is obviously very important. Is there a focus or a research going into preemptive AI, so looking into how to detect these earlier than experts can at the moment, or possibly trying to get treatments earlier? So
the second project, the follow-on project that we've done with DeepMind is on AMD, age-related macular degeneration, commonest cause of blindness. There's a dry form and there's a wet form, which is a more severe form, where we've trained a deep learning network to predict 6 months ahead of time when the conversion to the more severe form will happen, so that we can look at preemptive treatment. But that's, can't talk about the results of that as of yet, but soon.
Yep.
Thank you for your incredibly interesting talk. May I compliment you also on your wonderful perception of what things were like 40 and 50 years ago, which is very unusual. You mentioned, there were two things I want to ask you. At one point you mentioned there were 15,000 eye diseases, and then you mentioned 15 diseases that were actually, or areas of disease that were being used in the AI system.
Yeah.
So could you elaborate on how far you think the technology will actually be applicable? And the second thing is, could you elaborate a bit more on what actually are the difficulties for getting from where you are now to the next stage with this gap? What creates the barrier?
So I went through some of that a bit quickly because I was conscious that I got a bit carried away on like side stories early on in the talk. But in answer to your first question, the 15,000 classification labels, actually, that would be like 1,000 examples of one disease, another 1,000 examples of another. So that's how it came down to the 10 categories that we chose originally. And also, that doesn't speak to, like, they are the 10 sort of broad categories of OCT features, as opposed, and so there could be like many different diseases which cause choroidal neovascularization as a final common pathway. So there's still a lot of subtleties about this that I couldn't go into. In answer to your second question, so as a humble clinician, I didn't realize that when you write a research paper with a machine learning algorithm, that the algorithm in that paper is a piece of experimental code that is essentially in no way ready to be used in millions of people all around the world. So you have the barriers in terms of the technical maturity. So you have to rewrite the algorithm from the ground up according to industry standards, good manufacturing practice, with sort of ISO certified environments and all of this sort of stuff that I don't fully understand. So you can get regulatory approval. So there's the technical maturity, regulatory approval. There's more clinical validation, which I touched on, which is we've proved it in Moorfields, but will it work as well in Cambridge or in Brazil or in, different devices and different environments, different photographers? So there's a clinical validation. And, then there's actually what are the commercial considerations? Like, how is this something, and I'm not involved in that side, but is this something that, how would this be used in the US versus in the UK, where you've got very different healthcare systems, and ultimately somebody has to be able to pay for these types of things. And then I think that there's loads of other pitfalls around the validation that you need to be careful about. And there's a concern that, for example, with AI systems, they might not make the same mistakes as humans, and the mistakes that they could be bad. And so a human dermatologist might have, not as good accuracy overall looking at a melanoma or something like that, but they might be more cautious in appropriate ways than an AI algorithm. And so, of course, when you think about the safety of those algorithms, one of the dangers is that, this is a homogeneous algorithm that will make the same mistake at scale all around the world and could lead to harm, whereas one benefit of human experts is we're diverse and we make a range of different mistakes, and maybe that somehow is protective in some way. So lots and lots of things to consider.
Thank you.
One question, please.
Please.
Obviously, you've talked to us about extremely powerful algorithms, but they're still tools.
Yeah.
And you just said in the last few minutes that you're talking about a clinician being involved. And that's why I wonder about your feeling about AI, the intelligence bit of it, because intelligence to me means a degree of self-awareness of human capabilities. And I wonder if you would like to comment on whether that is appropriate or not.
So I think a lot of experts, computer scientists and engineers, perhaps rightly don't like the term AI, and they think it sort of contributes to hype and things like that. I, for better or for worse, kind of like it. And maybe it's just because of like watching science fiction movies and things like that. I just think it's a nice, and we might as well enjoy it while everybody's excited about it for the time being. Having said that, I think that it sounds great to give a talk like this around AI, but you can be very sure that once our algorithm is being used in routine life, everybody's going to forget within half an hour that this is some sort of AI. It's just a tool doing quite a narrow task. In no way is it some kind of like sentient artificial general intelligence or something like that. So I would agree with that point.
Thank you.
Pease. I was absolutely fascinated that the algorithm was able to determine whether a scan was from a male or female subject. Have you, or has it been determined whether the algorithm could determine whether the patient was, the patient's height, the patient's weight, or maybe even more controversially, the patient's sexual orientation, their religious affiliation, their politics, or all kinds of other attributes that you never normally think to look for in the retinal scan?
So, So I think I should be careful with that one. As an aside, there was some trouble on Twitter around, we used the term gender instead of biological sex, and I think biological sex is the preferred term than gender at the moment. I think we need to tread carefully here, in all seriousness. I mean, deep learning is not magic. There are some things where it can find associations, but there has to be something within the images that is there. It can't just make up stuff. And you see all these crazy things. Like there was a paper last year from some researchers in the US that got a lot of attention, where they downloaded thousands of images from dating websites, along with the label of the sexual orientation of the people on the dating websites. And I don't know how that was available or what the governance around that was. But then they claimed to be able to train a deep learning algorithm to then say whether someone was gay or not based on the fundus photographs. Or not fundus photographs, the facial photographs. And of course, that got a lot of controversy at the time. But the point is that actually it was very quickly debunked by researchers at Google and many other places who said actually, so in the paper, the researchers made all these claims about maybe there is some biological difference between someone who is heterosexual or homosexual, and maybe the lines of their jaw, they've got a more prominent jaw or something, crazy stuff like that. And this relates to hormonal exposure in pregnancy and crazy stuff. And all these machine learning experts around the world immediately just looked at the data and saw that, like, actually there was different things on, say, like a gay dating site versus a heterosexual dating site, of different kind of like cultural or social things that were used, like whether makeup was used or not, or the tilt of the head in taking the photograph, or whether glasses were worn, like all these other things that they found that if they controlled for those things, the deep learning algorithm suddenly was not able to work at all. So again, it just points up to the caution around us drawing conclusions, and even the caution with saying from a retinal photograph whether it's a man or a woman. We've done some external validation of that, but actually we still need to be a bit more careful before we get unduly carried away, like I'm prone to from time to time.
We'll take one last question. It's just gone 9 o'clock.
Thank you. Where are the hubs of innovation to retrieve the data to create these clinical applications? Are they primarily locked down to academic environments, especially in the healthcare setting? So, for instance, you're from Moorfields. The other example you used was from Stanford. Is that primarily where we'll see it, or would it be in private organizations?
I mean, I think it's a good question. I think we're fortunate that there are many efforts within the UK, not just our work, that are at the cutting edge. There are some centers in the US that are very good, and then you see a lot of papers from China and the like. So I think what people don't realize, maybe who are not really intimately involved, is that actually one of the biggest blockers is the data. And now if you've got a massive, well-curated data set, you can potentially work with an AI partner, whether it's an industry or academia, and if they can, within weeks, they will be showing you things that will make your jaw drop if you've got the right data to give to them. The problem is getting that data. And there's something that I call, or it might be, maybe I shouldn't claim credit for it, it might be Neil Lawrence, who's referred to it as hearsay data. So in other words, people will tell you, I've got 10 million OCT scans, but then actually that just means they have 1 million OCT scans. But of that 1 million OCT scans, only 100,000 of them are in digital form. And of that 100,000, only 10,000 actually have labels associated with them. And of that 10,000 labels, only 1,000 of the labels are actually correct labels. So the numbers get very small very quickly, and that's a major blocker. And in my experience, I guess I'm not directly answering your question, but in my experience, working with DeepMind, is that a lot of clinicians would approach them, and I would occasionally sit in on some of the conversations when it would be related to ophthalmology, and it would always start with them saying, we've got the world's best data set. And then they would say, well, can you come back to me? Can you come back to us when you know how many and what percentage of labels? And the clinician would say, I'll be back to you next week. I'm really excited about this. And then you never see them again. Because it really takes a lot of meticulous, hard work to be able to answer those questions. Now, I think that we in the UK have the opportunity to build that kind of lead in that space if we can kind of take advantage of the data that we have. But of course, that brings with it difficulties not just related to the technical and the manpower issues of getting the data, but something we haven't talked about, and maybe I shouldn't, I can talk about this some other time because I'm opening a whole other can of worms, but how can we use clinical data from the NHS in an appropriate way in terms of patient and public involvement, transparency, ethics, information governance, data protection, so that we can maximize the value in terms of patient benefits, but also in terms of benefits to the NHS and to the UK, and even kind of globally. And so that's, I think, a bigger question. One of the nice things that we're in a position with here in the UK for is that there's been this organization founded, which I think is amazing, called Health Data Research UK, HDR UK, based in London in the Wellcome Collection, which is the mission of HDR UK is to try to think about this narrative of how we can get the best benefits and value from our data. So I think like the UK is as good a place as any in the world to do this type of work.
It's a great note to end on. Could you join me in thanking both our speakers for great talks? And thank you.